let's go back to your older patient who maybe has some comorbidities, who turns out to be BRAF mutated. So how are you going to, what criteria do you use with the BRAF mutated patient? You have options of immunotherapy. Yeah. Sort of the urban legend was always that you would get that tail on the curve only with the immunotherapy, not with the targeted therapy. But after this ESMO, I'm not so sure that's exactly correct. So how do you use the data to make the decision?
Yeah, thank you for this question. And let's stick to this patient, because it was exactly the question. Actually, he's a person who has a lot of connection to Sloan Kettering, and he also gets the opinion of Sloan Kettering. And in his situation, though, he had extensive liver metastasis and he had extensive bone metastasis. He had a LDH above 1,000 and he was symptomatic. So he was really suffering a lot. He had incredible bone pain. And we have recommended a targeted therapy combination, BRAF-MEK inhibitor, and then he get a second opinion at Sloan Kettering, and certainly the alternative treatment would be a combination ipilimumab-nivolumab. But at the end, the colleagues in Sloan Kettering agreed, because the patient had really heavy bone pain. He was on morphines. Well, we need immediate action.
Right.
And the patient was also very happy, because he had the idea that he wants to go back to his office as soon as possible, which was very brave at this moment. But actually he did. And he had a wonderful response, and this response lasted for 9 months, and now he's on immunotherapy.
Although paradoxically, even though I assume we all probably agree we would want to give the symptomatic patient with a rapid pace targeted therapy, Axel, it's not exactly that patient that will be the one who benefits, because can you discuss some of the, I guess it was Georgina Long who published it already, the dabrafenib trametinib data on the low disease burden patients. So
yeah, there's several releases of data on the combos of BRAF plus MEK inhibition. It's not only for dabrafenib and trametinib, but at the EADO meeting a couple of weeks ago, it was more or less the same data for cobimetinib and vemurafenib. So it's very clear that the patients who have the best benefit in the long run, and the longest observation period is 3 years now, is a patient with low LDH, with less metastatic sites involved. So simply the patients who are doing well, ECOG performance set of 0 or 1. And this is true for almost all drugs, including chemotherapy. So we were knowing from chemo already from the old days of DTIC that the best patients for DTIC patients are with low tumor load and low tumor volume. I know that LDH is also discussed as more than reflecting the tumor load. It's a biomarker, it's different biology of metastatic melanoma, but still it matters for all patients. And therefore, we have a high medical need for patients with high LDH. These patients are still not doing very well. And I would have made exactly the same treatment decision in your patient. For symptomatic patients, for patients with multiple brain mets, for patients where you need a rapidly induced response, I believe BRAF plus MEK inhibition is still my first choice, but not because, the other drugs are inferior. It's simply because the speed of the response is so impressive.
Okay, but it brings up an interesting point. Would you then give them a brief burst of BRAF-MEK and then switch to immunotherapy? Have you ever done that?
Well, that's a big question, because a lot of physicians do that in spite of being totally uncontrolled, because these are data that we are not going to get to have in the community, and we won't know what to do. So I'm strongly in favor of doing that in clinical trials. But it's not so easy to organize quickly clinical trials to address this point. So I don't do that, because when patients respond, especially because we have these long-term responders with combination of BRAF-MEK, at 3 years we are now having the results, 45% of patients surviving. So this is the same that we're going to have with anti-PD-1 probably. So, but it's true that for a subpopulation of patients with high LDH, you're afraid that they are going to relapse earlier, and you would like not to wait until the relapse is very difficult to treat with immunotherapy.
So again, the urban legend is that you would treat the high LDH, high disease burden patients with targeted therapy, and then you'd give the lower disease burden patients maybe the single agent immunotherapy. Should we flip it, Dirk? Should it be the other way?
I think we have the best data actually for targeted therapy. I think we have very convincing data for patients with normal LDH and, for example, patients having only 1 or 2 organ sites involved with a
70% alive.
70% at 3 years. And I think this is very remarkable compared to the 5 years ago. And whether this is achieved in patients with immunotherapy, I think it's still open. I think we need to see these data, and this is too early for checkpoint inhibition, particularly PD-1 antibodies.
So it's actually the same population of patients that we would say they are good candidates for immunotherapy. So these patients with low tumor burden and low LDH, we know they do very well in combined targeted agents. So we still have a problem for high LDH and very high tumor burden patients.
But I want to come back to Jeff's point that start with targeted therapy and convert, for example, a patient with high LDH into a normal LDH patient, and then continue with checkpoint blockade. Also, this is driven by an idea, but not by data. So I'm absolutely supporting Caroline's notion that we need to treat these patients in clinical trials, because, I mean, how long do we treat? Whether to the point of best clinical response, to a normalization of LDH for 2 months, for 3 months, for 6 months. So, I mean, this is gut feeling, and I think we should try to have a concept based on evidence.